Good morning and good afternoon. On behalf of the Health Equity Action Network and Dr. Mandana Khalili, who is traveling, I'd like to welcome you to this month's learning webinar of the Investigator Skills Development Unit of the Research Coordinating Center to Reduce Disparities in Multiple Chronic Diseases. I'm Dr. Edwin Chalbois, Director of the Coordinating Center and Associate Director of the Investigator Skills Development Unit. First, I would like to acknowledge the Ramaytush Ohlone people, who are the traditional custodians of the land that UCSF and my home sits on. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who called this land, this land that UCSF sits upon their home. We're proud to continue their tradition of coming together and growing as a community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. Land acknowledgements are not enough. We must engage in true partnerships with community. And if you're local, I actually encourage you to support with your patronage our regional Ohlone People's Restaurant Cafe Ohlone. So moving on to our topic today. AI is here. It's not coming. It's here. It's a tool to be used by you. It's a tool that is being used on you and your data, and has significant implications for health equity. One of the Health Equity Action Network's focuses is actually looking at representation and AI and its promises and perils. And there's nobody I can think of who is a better expert than the one that we call upon on all things AI and bioinformatics, Dr. Will Brown. So we're really fortunate today. This is a follow-up and an update on his mission to inform us about what's going on with AI, how to take advantage of it, and how to increase health equity. Dr. Brown is an associate professor in epibiostat at UCSF. He runs his own code lab, and he's also the co-director of a T32 on health research fellowship program, and is involved at the national level in the American Medical Informatics Association, and has had a long history of health equity and HIV informatics work. So join me in welcoming Dr. Will Brown. Dr. Brown.
Good morning, everyone, and thank you for that introduction. So the last time I was able to talk to this wonderful group of young and up-and-coming investigators, it was a introduction to artificial intelligence. It was a what is it, what our feelings are about it, and how is it being used? And that was at our HEAN conference late last year. And this year, I actually want to really touch upon what Dr. Chalabaw was saying about the disparities and really focusing in on bias. And what I want to introduce you to is some work that we've been doing since my last presentation with this group, with Dr. Kim Rhodes and Stuart Gansky and some other leaders in the Health Equity Action Network and here at the RCC, in creating a session with community partners around understanding the bias that can be injected at many different vantage points into artificial intelligence that can really have some significant and consequential impacts on the patients and community members and people that we want to serve that encounter the artificial intelligence itself. So I will be giving you the presentation that I worked on from that work and that is ever evolving. Now, this presentation will revisit many of the points that we talked about back in the Heen conference, at the Heen conference, reintroducing some of the earlier conversations that we had about artificial intelligence and what it is and how we feel about it. But then diving deep into the issue of bias in artificial intelligence. So back when we originally discussed artificial intelligence, we had a conversation about, how many of us felt, it was the promise, and how many of us felt it was the peril, and how many of us felt it was somewhere in between. And at that time, I'll remind you all that it was roughly a third, a third, a third. Some people thought that it really did have the potential to get us to a utopian, or at least to head us towards the direction of some of the utopian ideals of how technology could really help advance society in a really positive way. And then others definitely thought that there was a strong potential or even greater likelihood that um, that the technology could really do a lot of great harm, and maybe even more harm than good in a lot of ways. And then people really thought that, ¿por qué no los dos? It could be a little bit of both, or we should even expect that that there could be a little bit of both. And part of that little bit of both, thinking about in the instances of peril, are the biases that we're going to discuss today and how that gets integrated into AI. But also, I want to remind you about, my personal philosophy is that AI, much like many of the different technologies that have evolved over time, is essentially a tool, and it can be one of those tools in a vast toolbox by which we navigate the world and get things done, get work done. Also, to review, the concept of artificial intelligence, AI, is more of an umbrella that encompasses other things that we may or may not be more or less familiar with. Machine learning, natural language processing, deep learning, machine learning being how machines make decisions, and natural language processing being how it understands the language that we speak and write, and deep learning with various levels of these things being layered on top of each other for more complex processes. And then a reminder of what is artificial intelligence. We went more into depth in our meeting back in September. But as a reminder, it encompasses machine learning, neural networks, natural language processing, and then from a more physical side of it, robotics. This is where it's not just doing the thinking and the computing, but it's doing the thinking and computing and controlling other mechanical tools that can actually do physical labor or work. And then some of the processing tasks, some of the subgroups of artificial intelligence in terms of like that are task oriented. So machine learning and understanding the thinking aspects, the text to speech, the speech to text was a part of the natural language processing, the vision and analyzing things like medical images and being able to identify, different conditions or masses at a faster speed or scale. Um, Data extraction, expert systems that can do really advanced or specialized tasks, and then helping us to plan and organize better. And then, as we said before with robotics, actually do physical labor. So, some of the advantages that we talked about were the speed and efficiency of artificial intelligence, just helping us do things a lot quicker, and hopefully with fewer mistakes. We can have a discussion about artificial intelligence hallucinating and making things up and things like that. But in general, as it gets smarter and better, a lot of that should also improve, and some of those hallucinations should decrease. Data analysis and pattern recognition for understanding, different outcomes in populations in terms of our research, or for improving how we conduct medicine, making it more precise in the age of precision medicine, rather than doing generalizable statistical estimations, and then using that as a foundation for treatment recommendation, taking a lot of the data from the individual, and understanding, the patterns, and analyzing, specific data or large swaths of data about a specific person, to understand, like what's going on at an individual level, what's going on a macro level, just all different ways that artificial intelligence is going to could potentially improve the way that we analyze data. Um, Talk briefly about personalized medicine, early disease detection, and then just drug discovery and development. This is something that is really starting to explode in the conversation around, or pick up steam in the conversation around artificial intelligence and how it's being applied to the development of new advanced drugs, being able to do a lot of the drug-drug interaction and analysis in informatics and bioinformatics, specifically, and helping us tease out the different uh, natures of drugs, so that we can then uh, more quickly identify drugs that can do certain things better. And then disadvantages and challenges, such as data privacy and security. And specifically at UCSF, one of the things that we are really big on is data privacy and security, because we are a medical university um, uh, that is mainly a hospital system, a teaching hospital system, but mainly a hospital system. And we often do research within clinical settings with very personal and private information. And so, as an example, we actually have our own artificial intelligence tool called Versa, two formulations of it, one being Versa Chat, which is more like a Chat GPT version of a text box that you can ask a question prompt and you'll get an answer, or you can put in data into that text prompt and ask the large language model to either do a task or some kind of analysis, or provide some kind of output based on the information that you put in it. And then our second one is called the Versa API, and that's where you can actually develop programs that do larger, more complex tasks with multi-level, multimodal data sets, things like that. And where data privacy and security comes along is this is our sandbox environment that the university has okayed us for P3 and P4 level data. That's de-identified data and identifiable protected health information data that can be used with that. And so it's sandbox and secure. So there's no going in or outside of the sandbox. Nothing that you put into it stays within the large language model. Nothing, and the large language model doesn't draw from outside. It's a snapshot large language model from a point in time that's updated at a specific interval. Then we have bias in AI algorithm development, and that's what we're going to really focus on a lot today when we have our discussions around health equity and artificial intelligence, and who are the people who are benefiting from it, who are the people who are most at risk for harm. And a lot of that is going to play itself out in a discussion around the way that bias seeps into or is specifically programmed into artificial intelligence systems. Uh, then there's limited interoperability, and this is where a lot of the disparities get exacerbated, because not every institution, not every community, not every person can get access to artificial intelligence that can be helpful to them, that specifically can do a task for them. And so we find that we saw a digital divide shrinking when it came in terms of like access to the internet and mobile technologies. And now with access to artificial intelligent technologies, we see that divide growing as well, including the uh, technological literacy around using artificial intelligence, which also contributes to that digital divide. uh, Ethical concerns, who basically, regulates the guidelines. There's so many different players when it comes to artificial intelligence, and so many different agendas as well that it really is uh, hard to pin down what is the gospel truth of ethics around artificial intelligence. But we can what we will have a conversation around the ethics, some ethical concerns that specifically are related to um, bias in AI and some disparities when AI is being used. And then the cost of implementation, which is another thing that further exacerbates the digital divide of the haves and the have-nots. Because even though at present things like ChatGPT are free or have a freemium model where you can pay for different levels of service, and even though AI is finding itself in all different aspects of our basic and daily tools, um, there is always a cost in the freemium model, or even the free model. There's the cost of just having to sign away the rights of giving up your data and what you're putting in and what you're saying, and the data that it's scraping from the internet and all that kind of stuff. We are our most valuable resource in the 21st century, has always been and continues to growingly be our information, our data, and how marketable that is. But then there's just straight up cash money. And so if you are able to pay for the most advanced and most helpful tools that are out there that are not free, then maybe you might have a leg up. If you are able to pay for the education around artificial intelligence, which is often not free, then you may have a leg up in being able to use those as developing skills that will then help advance your research career, your academic career, get you a new job in industry, et cetera, et cetera, et cetera. So the cost of implementation in different hospital settings, in different academic settings, in your own individual life, can often be a cause of great disparity. And then many of these feed into the challenges to access it. So, of those who have access to technologies that can support artificial intelligence, that is a specific set of people who have the latest and greatest and fastest working technologies. If you are an individual, or you know individuals, or you work with individuals who can't afford the smartphones or the computers, or don't work for institutions where the top of the line software and technology and processing speeds are made available, then the artificial intelligence, that even the free artificial intelligence that you use, will either not work to its full capacity, maybe slower, maybe more clunky, or just may not work on your device. So that also can be a part of the disadvantages and challenges around artificial intelligence. So hopping right in to bias in AI, really we can think about bias in AI in four different segments. The world in which we live in, the data in which we provide to that world, the design of the artificial intelligence itself, and the use of that artificial intelligence. And so, in terms of the real world, we see real world patterns of health inequity and discrimination. And this can show up in several forms. Some of those forms are in unequal access and resource allocation and discriminatory healthcare processes in biased clinical decision making, and we can talk more in the discussion part of this about what that means when we break it down, giving real world examples. But in terms of discriminatory data, sampling bias and lack of representative data sets, and this we often have talked about this before artificial intelligence, before AI, when we're just doing our normal research, where we want to make sure that we're recruiting samples that are representative of the populations that we want to serve, or a diversity of samples so that the outcomes that we're seeing, the results that we're seeing, are more generalizable to the larger community. Um, but the same is true for how bias gets into can be seep into artificial intelligent systems. Patterns of bias and discrimination baked into data discrimination. So how we collect our data, if we're collecting our data in a biased way, then that will also influence and introduce bias into the artificial intelligent tool, um, uh, also. Then bias AI design and deployment practices. So the data can be, even if the data is good, even if the data is diverse and plentiful, well, what are some of the developmental processes and the decisions around designing the use case and the thought algorithms of the tool that also carry bias with it? So power imbalances in agenda setting and problem formulation. This is why for us, it's really important for both our data harmonization and data management unit and our community engagement unit to work closely with each other, at a minimum behind the scenes, to make sure that we're on the same page, and that we are, as a data management unit, strongly advising and assisting in each one of the projects, um, engaging with their community advisory board and their community leaders on what type of common data elements are important and necessary, and what are feasible to collect from specific different groups, and making adjustments in between. Uh, Biased and exclusionary design, model building and testing practices, as well as biased deployment explanation and system monitoring practices. So again, who are the haves and the have-nots of getting to say what the AI is to do, what it's to look like, and then who is it said that it is for, or who should benefit from it. All these happen behind the scenes before it actually gets deployed, and all these have a large impact on the bias that can be baked in to the artificial intelligence. And then lastly, but not leastly, application injustice. So disregarding and deepening digital divides. And we talked about how that can happen with who has access and who has money, and who uh, who's making the decisions on access. And then exacerbating global health inequities and rich-poor treatment gaps, hazardous and discriminatory repurposing of biased AI systems. And a common one of that, and which is kind of already represented by the image in the figure, are facial recognition through cameras and for security, and where we've already heard stories about certain facial recognition technologies using footage and trying to leverage artificial intelligence in order to identify different perpetrators of crime, and end up falsely identifying perpetrators of crime because our because facial recognition algorithms have been repurposed for this new policing task, and that going backwards through the system of design back to discriminatory data practices, that maybe those original data sets did not include enough faces with melanin in them, darker tone faces, so that the facial recognition algorithms were did a better job at identifying and discriminating, or being able to discern one darker tone face from another darker tone skin color. So at this point, actually, I should have let's talk about some of the data types. So what are some of the common data types? What are some of the what common types of data are there? So we have structured data, unstructured data, which is well organized and highly formatted. This is the most common data that is used to build artificial intelligent models. We have unstructured data, which is also heavily used, particularly in large language models, for because unstructured data is usually how our language is presented and processed, and these are often in the form of some kind of data text. There's imaging data um, that we can feed into AI models, where we use human raters in order to teach the AI models what um, uh, patterns of different images are likely a tumor, or likely a embryo, or likely um, a smile or a frown, or this person versus that person, or a dog or a cat. And many of us may not remember, but we've been working not behind the scenes, but for these different large companies such as Google, and helping them with their facial pattern recognition, and Meta, and helping them with their facial pattern recognition, their image recognition, since for decades now. Because every time you would tag somebody in a photo, it would understand that that face is that person, and anytime you would tag them in a location, it would understand and remember elements about that location. And then doing that on a scale of many hundreds of millions of people across the globe, just really help to improve the artificial intelligence algorithm that is now using neural networks to identify things on its own. Audio data, where the when we use our voice for different things, when there are recordings and podcasts and video data, where there is YouTube, and the what we find ourselves in is a world where we're constantly providing more data for these companies to be able to scrape and learn, and more data that we're tagging and putting in different labels, and having mixed modes of data, where we have images, audios, videos, all these things working together, and learning from that, um, learning from us on what that is, and now being able to perform tasks and even generate new things that didn't exist before, all on its own. This is what we call generative AI. So if you've ever heard of the term generative AI, that is specifically artificial intelligence that generates something that technically did not exist before. Some other stuff, other types of data that we are very familiar with in our own work are time series data, sequential data collected over time. So it understanding things not just in a single moment, but being able to analyze data that has been collected with a now dimension of time, therefore being able to think in a time spectrum or use that dimension of time in its processing and decision making and um, ge generative AI tasks as well. Geospatial data, spatial information related to geographic locations, geotags, uh, zip codes and neighborhood data and all those things that help us, physically place people and objects and resources. And then sensor data. And this is something that we have been freely giving since roughly 2007 when the first smartphone came onto the scene. And then we then started to incorporate GPS into the smartphone and who we're calling and who we're texting and who we're tagging on all these different social media, all from one device that knows more about us than anybody else in our lives. And this is all from sensor data that we get from the watches and the smart rings um, and the new smart beds and the new smart security systems. And all those things have sensors that without us having to say, this is what I'm doing, this is what I want you to know, it's collecting the data usually in real time. And then biometric data, which usually goes hand in hand with sensor data in terms of really getting down to the nitty gritty of what's going on in our biology, information that we ourselves might not even be aware of or know. Our heart rate. We're not going to be able to post about our heart rate unless we have a tool, a sensor that tells us what our heart rate is. Most people, can't process all the different things that a sensor can pick up on and that tells us what's going on with our physical and mental and in many cases emotional selves. And then lastly, but definitely not leastly, our healthcare data, our social media data, and our financial data. These are extremely sensitive data that fall under that category of high privacy. So, with the exception of social media data, that we have options for, allowing people to see or not see. We can put privacy metrics on there, but more specifically, the healthcare and financial data that we have are usually data types that we hold closest to our chest and keep secure. But even those are being made more available for research purposes and then sometimes through social media when we're just talking about our day and how we feel, or if we got hurt, or checking in on an emergency or anything like that, our healthcare and our financial data can seep in into the larger lexicon of open and freely scrapable data through social media. So we can make these three data types very private, or we can make them very public. But for the most part, these are the data types that a lot of us find to be very sensitive and that we may scrutinize a little bit more. And then there's just stuff that may not even have to do with us specifically, or the people that we are wanting to serve, but these are data types that AI leverages that larger organizations usually control, open data sets, government agencies collecting data and curating data and putting them all in all in one location. That's one of the tasks and goals of our entire network of our consortium, is to have all of the data that we are collecting, to be used symbiotically to answer new questions that we may not have been able to do otherwise. And so there are conversations around the appropriate or use or inappropriate misuse of artificial intelligence in the data that in and around the data that we're collecting. And let me reassure you all that these are just conversations that we're beginning with, and that we are not in any kind of way using artificial intelligence with the data that we're collecting within the Health Equity Action Network as at present. And any of those conversations will make sure that are network-wide conversations that we really get an understanding of where everybody is and what our thoughts around that. But then also research institutions. And the most salient example that I can harken back to is the fact that at UCSF, we already have built our own and started using our own artificial intelligent system, both for research and in healthcare practice. So not only are researchers using artificial intelligence tools, the Versa chat and the Versa API for more complex and robust analyses, or to help develop new tools for research purposes. But because we are a medical and health institution that is patient facing, we are also already developing tools that are being immediately implemented into our hospital system and are being studied for quality, for different outcomes, for efficacy and things like that, such as uh, automated scribes and new disease detection tools, and um, uh, patient decision aids and clinical decision support tools, and making these things more advanced, robust, and potentially better if done correctly. And so the last thing is, how are some of these things gathered for artificial intelligence? Well, I think the most commonly known is web scraping, where the artificial intelligence is just scraping the data from the internet. Then we have application interfaces that allow us to either add and put in new data or extract out data from these tools. And then there's this concept of the Internet of Things devices, including sensors and smart devices that generate large amounts of data. Um, and we talked a little bit about what some of those types of data are, be it, heart rate or um, uh, uh, blood glucose monitoring and things like that.
Phone cameras.
Phone cameras, enterprise data, sensor network, social media platforms. Again, all these are all, uh, things that big organizations control, and have the potential to either incorporate or collect more data and put into these systems as well. I was just signing up for uh, uh, something in my health tool. No, I was signing into my health tool, and they had for Kaiser, and they're now leveraging my chart, and which is a different system, interface system in the app than they had used previously since the last time. And so I had to, sign away my data and life all over again, and go into the fine print, otherwise that you still have to say yes to. Otherwise, even if it's a health tool, you still have to say yes to, um, um, if you want to be able to use the convenience of the app. And then healthcare institution, financial institution, and educational institution data. So these institutions are also offering up their own data as well. So where can we intervene? And this is where I'm going to stop for a second and allow for us to have a conversation about where we can intervene. We've gone over a lot of these different elements, but given some of the things, given some of the things we've discussed and some of the things that I've mentioned, um, what are some areas that we think we can intervene? So, Edwin.
Yeah, well, this is all fantastic background information. One of particularly those I think concerning are those behind the curtain sort of things. Those what are our opportunities to intervene on those pre-deployment things where those structural biases are really problematic? Like how do our communities impact at that structural level?
Yeah, absolutely. One of the phrases that I've heard you say, that I've heard Kim Rhodes say, that we often commonly say is nothing for us without us. And one of the ways that I think the most basic way that we can intervene and try to start eliminating bias is to engage, make sure that we are actively engaging. Some of the challenging things that I see, particularly in communities of color, um, is a fear to engage. It's like, oh, if I do not participate, it won't have my data. I won't be involved and I won't be a victim of whatever this thing that other people are using is. And that's just not true in this day and age. We give of ourselves in terms of data in ways that we don't even realize, and we give of ourselves regularly. And even if you don't give of yourself. And even if you don't engage, that doesn't mean that the tool won't be developed without you, that it won't be developed without your data, that it won't be developed without your input, your voice, your thoughts, your wants, your needs. And it will be still implemented likely in some kind of system that you ultimately have to engage with, which puts you at risk of being harmed by that system because it doesn't know you. It's not thinking about you. It doesn't care about you because you weren't a part of its thought process. It didn't engage with you because you didn't engage with it. So what does engagement mean? Um uh what does addressing bias through engagement mean? That means if you are a part of a team or a developmental team that is thinking about implementing some artificial intelligence, that means talking to the developers and asking them how this works and how it was developed. You asking for specifics about the tool's purpose and the tool's design. If the tool is to be drawing from a specified data set, asking, what is the representativeness of that data set? Who's included? Who's not included? Am I included? Is my community included? And if we are to be included, what are the safety and privacy protocols that will be put into place to make sure that even though I am being included so that the tool can do a better job at servicing me, that my data is still safe and that other outside agencies, organizations, or potentially bad actors won't gain access to my data for other purposes other than what I intended it for. So those are just a couple of things. Anybody else on where can we intervene or engage?
We have a raised hand from Eduardo.
Eduardo, did you want to?
Sorry, can you hear me now?
Yes, yes, we can hear you
Oh,
now.
I was talking. Okay, sorry. So thank you very much for this talk. It's actually really important and interesting to have. One thought that I'm a PhD student in the epidemiology and biostatistics program, and I've been using AI for a while now. And one thing that always comes to my mind is that the algorithm itself. So when you use a random forest or whatever algorithm of machine learning and you apply it without touching it to data, if there's some kind of bias, it's actually picking up the signal of some kind of bias that is, like you mentioned, structurally already in the system. So I think that it's also important that when we are developing these tools and we are finding these signals, it's important also to bring them up and not just try to address them, because yes, it's our task to de-bias the algorithm, but it's also important to bring it up to the stakeholders, like, so like in the example that you say, I think there was a paper on some algorithm that was discharging, I believe, people of disadvantaged socioeconomic status faster because they were not paying enough, or it had something to do with the financials of that population. Bring it up before that happens, right? If we find the signal while developing the app or the algorithm or whatever, bring it up to the clinicians, patients, hospital administrators. I think that's also the transparency when developing these tools is an important piece.
Yeah, absolutely. Making sure that there is some kind of evaluatory process that helps us understand the performance of the tool and not just the performance of, oh, is it doing this fast? Oh, is it doing this at as purposed? Because often the purpose is to improve profits, make things more efficient, and make things just faster in general. And it's usually great at that, great at those things. But we have to talk about the making non-discriminatory outcomes be a part of that evaluation, a part of the purpose. Make sure that the different metrics for evaluation really assess whether harms are being done, and that even if there are expected harms, going in, like, okay, these are already some of the biases and some of the things that we know already exist and that could be happening and that we'll look for when it's finally deployed. But what are some of the ways in which we can find some of those things or try to detect those things that we didn't already foresee? So having a robust evaluation protocol when you're implementing these technologies in any setting.
Yeah, and that's actually a great segue for my second thought. I was involved. We were doing a project on using large language models as agents to try to make kind of like a group of experts, an artificial group of experts, to come up with some clinical decisions. So the interesting part for me is, and some thought that came up to me is also involvement of the community, that where the tool is going to be deployed, right? Because the optimality usually means different things for different groups. So if I'm a clinician, like you were saying, probably my goal will be to provide a faster, see more patients, for example. I don't know, I'm just making it up. But maybe for the patient, it might be some optimality might mean something different. And I work in neuro-oncology, and usually the optimal or the best course of treatment is to resect a tumor. But that comes with side effects and with other consequences. So for the patient, maybe quality of life is more important than resecting the tumor, and maybe resecting the tumor is going to lower their quality of life. So that's a conflict between the clinical algorithm, I'm going to call it, and the patient preferences, and those are really important also to capture, and they're difficult to capture in a quantitative way, and therefore implementing them is difficult as well, but it's important.
Thank you so much for that. We have a question in the chat, and I'm not exactly sure. I would love if it can be restated, but the question's from Wendy. It says, in this age when we are expected to make data a code public when we publish research, do you have any advice about whether or how to control future use? Okay, no, actually, I think I understand. Um, I think it's challenging. I think it's challenging, and I would have to actually think about uh, ways to control for that because even within the Health Equity Action Network, um, people are subject to the rules, regulations, and promises that we make to our funders. And as one of our and one of the expected things when we all applied for the different types of funding to be a part of this network was to share our data uh, together and in specific ways. Now, that has evolved over time, but it has evolved over the
Yeah.
via
Is
the
it research? Is it profit? You know, how do we
yeah,
apply our principles? You know, is it, you know, what's the intended use case? Your, you know, nothing about us without us sort of principles. I think those might be all reasonable things to apply. You know, the NIH guidance was meant to foster open research. It wasn't meant to foster for-profit businesses or
100%.
nefarious purposes, et cetera. So I think
Absolutely.
I think those are, you know, I always go back to what are our core principles and how do we enact those and engage those people who want things from us in those, get some mutuality around those around those principles, around the processes that we think should, you know, that should be in place in order to ensure health equity and those sorts of things. I mean, that's kind of what comes off the top of my head. But yeah, it's like once you give something away, it's like you kind of lose control over it. So it's at that sharing stage, I think, is where our opportunity probably is.
Absolutely. Absolutely. Well said. Any other anybody else on where can we intervene or engage? Well, just going back to our original diagram, well, let me back up because I think this was out of place. So, um, we can engage, you know, just going back to our original diagram, we can engage in the real world, in the world around us, in these in terms of access, in terms of discrimination, in terms of decision making, who's making these decisions, and then also in terms of the data and what data we're providing or what data we're allowing and what data is missing and calling that out. And any other different kinds of baked in biases from previous data. The use case for it, who controls the data and says what purpose it's going to be used for, or or where the artificial intelligence is coming from and what purpose it's going to be used for. And then also in the design of it, you know, how is it being built? Why is it being built? What are the motivations of those who are building those tools? Are there any other thoughts around this topic, around or any questions around uh, inequity, discrimination, bias? One question that Eduardo put in the text is, should the IRB modify practices to screen uh, differently AI projects? I would love to hear what people's thoughts are around that.
I think we need to make sure that IRBs are aware of these issues. They need to watch your talks, Will. I think understanding understanding the issues I think is an important thing. So I think that's one of the opportunities I think for us is to approach the different IRB panels and say like, what do you guys need to know about AI in order to do your human subjects protection job.
Anyone else?
Yes.
Has anyone tried? Go ahead.
Yes. This is Dr. Stephen Shudak of Tuskegee University. I just like to offer an insight. I agree with what just said. In the event that all of the guiding documents that got us to where we are today actually need to be reconsidered in the light of what these challenges that they are. That's what I have to.
So it was slightly hard to hear you, but what I understood was that the documents and the processes that are currently the standard for IRB need to be reconsidered. And I think that's actually true. There does need to be some evaluation. Some things will stay, some things will go, and some things will need to be updated. Because we're also having these conversations not only about our IRB protocols, but about the grants themselves and how AI plays a role in, writing different things or assisting us in writing different things. But also, there may become a point in time where the artificial intelligence is the first reviewer of your IRB packet. And what does that mean? And then also, does the IRB have enough knowledge about um, the use cases and dangers and pros and cons of artificial intelligence, the harms that it could potentially do of artificial intelligence to make a full and accurate assessment of the risk level to our participants in order to give IRB approval, to give human subjects approval. So I think a lot of these questions still are not fully answered and are slowly being tackled. But the IRB is traditionally one of our slower moving and evolving institutions. So we'll see. And AI is so incredibly fast. It's the development. It's not only fast in its ability to do tasks, but it's very fast in how quickly it's growing, expanding, getting into every aspect of our life and being developed.
Well said.
But
Well said. Well said.
thank you so much.
We're at the top of the hour, and unfortunately, Dr. Charlebois had to run on to the next meeting, but I just want to thank so much. Really, my hearty thanks to Dr. Brown for this amazing talk and to all of you for attending. This was really fantastic. Thank you so, so much. I'm sure that we'll be hoping to offer future webinars continuing on this topic, which is so relevant and really of interest to so many people. There I am. Sorry, it was my blank screen. Thanks so much.
Thank you.